around the world. Today's program will be brought to you in 3 individual segments. Our first segment will be talking about the HIV epidemic within the pandemic, which is the coronavirus. Our second session, which begins at 12 noon, will be talking about keeping it 100, the facts, the fiction, and the real deal on HIV. Our last and final session will begin at 7:00 p.m., and we will be rocking the ribbon together, acknowledging HIV heroes in our communities. Throughout the session, we will be entertaining audiences via Zoom, as well as Facebook. Welcome to everyone. We want to remind you that you are able to put your questions in the chat box, and you can also type your questions in the comment section on Facebook. I'm going to introduce to you our first moderator for today. Our moderator is Tenitra Batiste. Tenitra is an anchor, reporter, and host for WZGC in Atlanta, Georgia. Tenitra also does pregame, postgame, and sideline coverage for pro, college, and high school teams across the country. In addition, Tenitra covers major sports events such as the Super Bowl celebration, as well as the NBA All-Star Weekend. Previously, Tenitra served as an anchor and reporter for BHSN. When she takes a minute away from sports, the proud Xavier University of Louisiana alumni teaches dance classes. She is also a member of Delta Sigma Theta Sorority Incorporated, a member of the Christian Education and Outreach Ministries of Elizabeth Baptist Church, and serves on the Diversity and Inclusion Committee for the Sports Task Force of the National Association of Black Journalists. Tenitra will be moderating our first session, which will be led by Dr. Lauren Collins, who is an assistant professor of medicine at Emory University. So without further ado, I would like to introduce you to Tenitra and Dr. Lauren Collins.
Thank you so much for that introduction, Tanisha, and good morning to everyone, and welcome to our Coffee Vibe session. I'm so excited to have the opportunity to speak with Dr. Lauren this morning. Dr. Lauren, how are you today?
I'm doing great. I'm so excited and honored to be here to rock the ribbon with you guys this morning.
Absolutely, absolutely. And there's so much to get into just in terms of what we're dealing with. You know, there's a phrase that my pastor uses all the time. He talks about how we're managing through this pandemic and the pandemonium that is going on in this country. And there are so many moving parts in what we're challenged with and faced with, but there are different populations throughout the country, if not the world, who are dealing even more so with layers on top of layers, if you will. So let's talk about what the physical challenges in this pandemic and pandemonium might be, specifically for those who are dealing with HIV/AIDS, which of course we know has been a global pandemic, and also may on top of that now be faced with the possibility of dealing with the coronavirus and what that might look like. So obviously we'll talk a little bit about that this morning, but the first thing I wanted to ask is, for you, Dr. Lauren, how has that really changed your focus in terms of dealing with the HIV/AIDS pandemic, if you will, dealing with the coronavirus pandemic, and just how those worlds have merged, especially across the last 13 months or so?
Absolutely. That's a great question to kick us off this morning. And I would say that the COVID-19 pandemic has completely changed everything that we do, you know, for me personally, but also professionally. And I think you're asking mostly about the latter. So, you know, we have had to completely kind of restructure and reimagine HIV care delivery in the clinic. I am a HIV primary care provider at the Ponce Center, which is through the Grady Health System, or the Grady IDP Infectious Diseases Program. And so, you know, I see patients in clinic there and also around it at Grady Health System, at Grady Memorial Hospital. And it has completely transformed all that we do, wanting to reach our patients in the safest way possible and continue to provide them with necessary services and support support through a really challenging time, and needing to do it in, you know, sometimes a virtual fashion if possible, to keep everyone safe.
And it's amazing work, as you know, that's always been done at Grady. You guys have dealt with over decades the traumas that we deal with and are challenged with in and around the Atlanta metro area. So certainly trauma is nothing new to the Grady family, if you will. But I do want to step back before we go into your presentation and talk about the reality of what it's meant for you personally. Obviously, we'll go into the professional aspect of it, but how has it changed things? How has this pandemic shifted things for you being on the front lines, both professionally, but also personally?
Yeah, thank you for asking. I think that as I think you brought it up so accurately and brilliantly when we started, by saying that I think no matter who you are, which background you're from, this pandemic has affected us all. I think certain communities are much harder hit than others. But I think some tolls that it's taken on my family and I have my husband and I, we have two small children, and so I think that has been the biggest challenge for you know, working families, to basically balance, you know, being you know, wanting to stay in the workforce, especially doing the work that we do. My husband's also an infectious diseases physician and at Emory, and
Wow.
so and he's also involved in the COVID-19 response. And so I think balancing this desire to really be a healthcare worker and being you know, also involved in research against HIV and COVID-19, and balancing that with keeping everyone safe at home, and of course how it's disrupted school systems, and you know, wanting to, or needing rather, to have childcare and learning in a creative way and in a safe way. So kind of balancing all of those risks and challenges on the day to day has really you know, been something for us that is it does feel like a daily conversation in our house, for sure, with some difficult decisions needing to be made. But you know, we fortunately have been able to keep safe and healthy, so we feel very fortunate.
Yeah, and you speak of that tightrope that everyone's walking right now so eloquently, and we appreciate you for that, and definitely, of course, appreciate you taking out the time to talk a little bit to our audience, the audience for Atlanta Suburban Alumni Chapter of Delta Sigma Theta Sorority Incorporated specifically. And so without further ado, I know that our audience is here to listen and learn of all of the fascinating challenges, even some of the triumphs that you've seen in the course of the work that you've done, both in the HIV and COVID space. So without further ado, Dr. Lauren, I'll ask if you'll go ahead and begin the presentation and really begin to share some of that information and enlighten our audience with what you know and what we'd love to learn.
Absolutely. Can you see the slides okay? Yeah,
Yes,
okay,
yes, we
great.
can.
So I will get started here. I have a few just, you know, kind of brief presentation that I really just want to kind of use to really lay groundwork for what I hope is a really great discussion involving all of you guys. So please, you know, store up your questions, and I'm really looking forward to kind of dialogue later on. And I want to begin just by thanking the organizers, by thanking the ERC and Delta Sigma Theta for inviting me today. It's such an honor to be here on World AIDS Day. I know this looks a little different in a virtual space than we would typically have being all together, but it is amazing that we can gather today regardless, and just be communal and celebratory on this day, as Ms. Taylor kind of kicked off by saying, truly is an international holiday. And I think in 2020 really has brought themes for World AIDS Day of impact and of resilience. So I just want to start with that, you know, those themes of impact and resilience, and hopefully that will be woven through here. So without further ado, I will really be focusing on when two worlds collide, the HIV epidemic within the COVID-19 pandemic. And just by way of brief background on the HIV epidemic, we know that there are approximately 1.2 million persons with HIV in the United States living currently. However, 1 in 7 individuals don't know their status. Strikingly, you can see here the HIV care continuum. And like I mentioned, 86% of individuals have been diagnosed, but only 64% are receiving care. Less than half are retained in care, and only 53% have well-controlled HIV, which we kind of term HIV viral suppression. And even within these numbers that I show here, it's a lot more nuanced than this, because we know that there's significant regional variation throughout the United States, and that certain populations are significantly more affected than others. And so I begin with this because I just want to emphasize that, we really view people with HIV as a diverse group of individuals that have very unique biomedical and also socio-behavioral considerations that must be taken into account during a novel viral pandemic such as coronavirus disease 2019 or COVID-19. So these numbers are staggering, and this was actually from about a week ago now, just before Thanksgiving, that I pulled these numbers from the COVID-19 dashboard that's been featured by Johns Hopkins, where we're nearly up to 60,000 global cases of COVID-19. I'm sorry, 60 million global cases of COVID-19 worldwide, including nearly 13 million in the United States. And you can see the global toll of deaths at a staggering nearly 1.5 million here. What does this look like in the United States, and how does this overlay with the HIV epidemic? So these maps are US county prevalence data for both COVID-19 on the left and HIV on the right. And you can see here, I think very clearly, the synergy whereby the counties most affected by COVID-19 are the same counties, more or less. There seems to be a significant geographic overlay of the counties where the HIV epidemic is ravishing. And of course, you'll notice that for us in the Deep South, we seem to have, many individuals and communities affected. And just to put a number on this, of nearly 38,000 new HIV diagnoses in the US in 2018, 51% were in the Southern United States. So just where we're located here. So we certainly have our work cut out for us in terms of HIV alone. And now we're adding the COVID-19 pandemic on top of it, whereby we get the term epidemic on pandemic. So from the onset of COVID-19, we as HIV clinicians and researchers and advocates and people living with HIV have been wondering, are persons with HIV at increased risk of acquiring COVID-19 compared with the general population? And are people with HIV more likely to experience severe COVID-19 illness? How do COVID-19 vaccines and therapeutics perform among people with HIV? And what is the impact of COVID-19 pandemic on people with HIV and those at risk for HIV on being able to access essential services? So I will kind of just very briefly go through what we know in terms of data to date on these various questions. So I want to start with just from a clinical perspective, because that's a little bit, or mostly where kind of the space I've been in the past 9 or so months, thinking about this pandemic and how it overlays on how we clinically care for people with HIV. So there are a lot of factors to consider. What could be mediating COVID-19 risk and illness severity for people with HIV? We need to consider the role of age, comorbid conditions like high blood pressure and diabetes and lipids. What about HIV control and immune function, which we typically measure by the CD4 count, and ART or antiretroviral therapy, and then importantly, social determinants of health. In the general population, it is clearly established that older age and comorbidities, so high blood pressure, diabetes, dyslipidemia, appear to be the strongest risk factors for COVID-19. And we know, given the success of antiretroviral therapy, that for those individuals that have access to therapy and are able to stay on treatment, that people with HIV are living longer. They're aging, which is it's a great problem to have. Unfortunately, it comes with also a high burden of comorbidities. And so in the latest HIV surveillance report by the CDC, strikingly, over half of people with diagnosed HIV were over the age of 50. Also, comorbidities in this population are high and increasing over time. So we already know that age and comorbidities significantly play a role in COVID-19, and that persons with HIV also are aging and have a high burden of comorbidities. So how does this play out for people with HIV? When we look at CDC or Centers for Disease Control.gov, they have a special page on HIV and COVID-19. I just want to read this because I find it really interesting and telling, which is that we're still learning about COVID-19 and how it affects people with HIV. Based on limited data, we believe that people with HIV who are on effective treatment have the same risk for COVID-19 as people who do not have HIV. Older adults and people of any age who have serious underlying medical conditions might be at increased risk for severe illness. And this includes people who have weakened immune systems. The risk for people with HIV getting very sick is greatest in people with low CD4 cell counts or people not on effective treatment. And I just briefly want to present a couple of data slides to see where this is coming from, given that this is CDC's guidance and take on the pandemic currently. And again, recognizing that while we're 9 months in, it's still obviously a very new virus, and there's a lot of work and ongoing research to try and tease these effects apart. So you can see here, there have been at least 8 published case series of people with HIV and COVID-19. And the demographics of these individuals being predominantly male, around middle age, and predominantly Black or African American is on par from these various communities: Barcelona, Madrid, Milan, London, New York City, Atlanta, Providence, Rhode Island, and Boston is about on par with the demographic of people with HIV in that locale. Interestingly, I just want to highlight that for people with HIV that were hospitalized with COVID-19 across the board in these communities, the HIV is very well controlled. So CD4 counts are high. We usually use a threshold of around 200 as a cutoff for AIDS. If CD4 counts lower than 200, that would be the severest case of HIV or AIDS. However, these individuals have had well-controlled HIV, with the majority being virologically suppressed and on therapy. Interestingly, the number of comorbidities is high, ranging from 63% up to 85% of individuals having several comorbidities. So, is it possible that among people with HIV, the risk of COVID-19 and illness severity is not due to immunosuppression and potentially due to other factors, including the presence of comorbidities, an overrepresentation of comorbidities in this population? I'm just planting seeds for things that we're thinking about from the clinical angle. And I did just want to briefly highlight the study that we conducted in Atlanta, which we looked at individuals that were hospitalized. This was earlier in the pandemic, from March 8th to April 23rd, within the Grady healthcare system, within the Atlanta VA, and at Emory. And out of 530 hospitalized cases of COVID-19, nearly 4% were among people with HIV, which is not more than what we would expect, just given the prevalence of HIV in the Atlanta population. And interestingly, in our study as well, the CD4 count was very good, above 200, and 90% of patients had HIV suppression. I just highlight here some of the comorbidities that we saw with a high representation in this cohort of patients, being hypertension or high blood pressure, lipid abnormalities, diabetes, and psychiatric illness, occurring in 40% up to 70% of individuals. And I just want to also point out that half of these individuals had at least 5 comorbidities, so a really high burden of comorbidities. Just one follow-up study, this was from Boston, had very similar findings, but they also looked at, well, where did these persons with HIV work? Where did they live? And they found that half had exposure to congregate settings, so group living situations, and a third were considered to be frontline workers. And importantly, 77% of persons with HIV that were hospitalized with COVID-19 were non-Hispanic, Black, or Latinx, compared with 40% of the clinic population, underscoring the role of social determinants of health and health disparities in mediating COVID-19, as we're all at this point in the pandemic very well aware of and actively trying to fight. So taken together, with a holistic view on caring for people with HIV during the pandemic, considering all of these factors, the Infectious Diseases Society of America and the HIV Medical Association have put out very clear guidance that starts with this extremely important statement, which is that HIV should not be a factor in medical decision-making regarding the triaging of potential life-saving interventions or enrollment into clinical trials. And this is paramount and something that we've been advocating for throughout the pandemic. It's also important that care and treatment for COVID-19 and people with HIV should follow the same protocols as advised for persons without HIV. We also suggest consultation with an HIV specialist for persons that are hospitalized, and this is mainly to do with management of antiretroviral therapy, which is to say that we prefer that ART be continued throughout the hospitalization without interruption. Finally, there may be the need to consider drug-drug interactions between COVID-19 treatments or therapeutics and antiretroviral therapy. So just something to keep on the radar. I want to hone in on the clinical trials because this is all the rage now. This has been all over the news about emerging data coming out. And again, want to emphasize that the guidance state very clearly that people with HIV who are virologically suppressed should not be excluded from trials, and that includes therapeutics, prophylaxis, and vaccines. Now, why is this important? This is important not only because we want to understand how these interventions perform among people with HIV, but we also want to guarantee that if there is an indication, for example, by the FDA or the Federal Food and Drug Administration, that if there is an emergency use authorization given to these therapies, that there's an indication for people with HIV as well. And I just want to highlight here in this table the column all the way to the right. So these are the various vaccines that are being studied for COVID-19 that have been featured most recently in the news with very promising data. And I just want to highlight here that the vast majority, due to intense advocacy in the HIV community, include people with HIV, which is really incredible news because we'll again know not only how these vaccines perform in this community, but also there can be an indication to give vaccines and other therapies to people with HIV as well because they've been included in the trials. And this, unfortunately, from a historic perspective, has not always been the case. So I just want to briefly go over what the process is for these vaccines, since it's been highlighted so much in the news recently. Multiple pharmaceutical companies, you may have heard Pfizer, Moderna, AstraZeneca, have released news that they have that their vaccines have greater than 90% efficacy or effectiveness in the clinical trials. So what are next steps? After the data is reviewed and reported on, companies apply to federal regulators for authorization to provide the vaccines more broadly, so to include not only the trial participants, but the general community. FDA regulators then review the effectiveness, safety, and manufacturing of each vaccine, and an advisory committee at the FDA votes on whether or not they would recommend the agency to greenlight each vaccine. As early as December, which of course we're kicking off today with World AIDS Day, December 1, the FDA may authorize one or more vaccines. And then days following that, the CDC Advisory Committee can discuss prioritizing vaccines for high-risk groups. And we can talk in the discussion a little bit as to who those high-risk groups may be. And it's anticipated that by the end of 2020, the government projects that Pfizer and Moderna will provide 40 million doses, enough for 20 million people to be vaccinated potentially by the end of this year. So shifting gears a little bit and wrapping up here, I want to focus on how the COVID-19 pandemic has specifically altered HIV care. We initially were told that we needed to stay at home. This essentially forced clinics and healthcare systems to reinvent themselves and develop telehealth services where for many systems and clinics that had not been in place. Pharmacy services also needed to get creative, how to think through getting antiretroviral therapy, which is a lifeline to so many, really to all persons living with HIV, to safely get them medications if we wanted people to stay at home. How would this happen? Via mail order, safe pickups, etc. Also needing to consider Ryan White and ADAP re-enrollment, where typically this is required every 6 months and could not necessarily be safely done if persons aren't able to get into the clinic and have labs drawn, for example, to check on what's normally required for these programs. We also know that the pandemic has severely affected our ability to screen and treat for sexually transmitted infections, as well as provide mental health services and substance use support. And then we're also thinking about not only people with HIV, but people at risk for HIV in terms of PrEP or pre-exposure prophylaxis. Is PrEP as readily available? And similarly, what about screening labs and STI testing and treatment and even testing for HIV that frequently go along with PrEP services? And I just want to flip this a little bit and say that COVID-19 has actually provided us an opportunity to reimagine healthcare or HIV care delivery. So typically before the pandemic, in most situations, this is how HIV care was delivered in a brick and mortar system, where a patient would see a provider on, kind of a 3 to 6 month interval in a traditional brick and mortar setting. And the individual would pick up their antiretroviral therapy from a co-located pharmacy in the clinic on a 30-day supply. Well, as many of you are well familiar with, this poses challenges to the vast majority of our patients. So what about this? What if COVID-19 has allowed us to reimagine HIV care delivery whereby we put the client or the patient in the center? And the provider could be available in a traditional clinic setting if that's appropriate, but also through telehealth platforms and mobile integrated health units or home visits. And what about, yes, if we still had a pharmacy located in the clinic, but we could supply antiretroviral therapy, not just in 30-day supply, because we know that's awfully challenging for people to get into a clinic every 30 days to pick up meds, but what about on the order of 3 to 6 months? And what if we had distribution points in the community and not just in the clinic setting, or we were able to deliver these medications by mail? This would be a lot more friendly for our patients and clients who are in need of these services. And finally, the pandemic has really illuminated the role of community healthcare workers to address social determinants of health. And I want to be clear, not only in times of crisis, but beyond. Once we're through this crisis and in everyday life, how community health workers can be leveraged to help us address availability of food, employment, housing, increase access to healthcare, and even work on legal issues or assist clients with legal issues, including immigration and documentation status. And HIV could be used as a model for other chronic disease management too, through the role of community health workers addressing social determinants of health. So finally, how to keep healthy. And when I say healthy, I mean not only our body, but our spirit and our mind. It can't be said enough that it's absolutely paramount to wear a mask, that wearing a mask saves lives. Washing hands, watching your distance, the 3 W's, wearing a mask, washing your hands, watching your distance. It can't be said enough. We're about to embark on a winter season that is unprecedented, and I highly encourage everyone to get their flu shot if you haven't already. As much protection as we can arm ourselves with, the better. We have to think about how we can ensure a continuous supply of medications, whether it be ART or PrEP or other medications for chronic conditions. And last but not least, how we can keep connected to our support communities, whatever that looks like for you as an individual. So I want to end by saying that I really strongly believe we have reason to be optimistic here. we have a lot of good news coming out, and we have the strength of our community. We have that resilience, and we're working on impact. A couple of take homes: that people with HIV appear to have similar COVID-19 outcomes compared with the general population, at least as studied to date, which is good news. There are many ongoing research studies to better understand the effects of age, comorbidities, immune and HIV control, as well as ART on COVID-19 among people with HIV. And we have very promising data from vaccine trials on COVID-19 that included people with HIV, and there's more there to come. And finally, the pandemic has provided an unprecedented opportunity to reimagine HIV care delivery and rebuild our public health infrastructure. So with that, I would like to thank my personal mentors in this HIV community space, including Dr. Igo Afodikin and Anandi Chef through the Emory CFAR. Additionally, Carlos Del Rio, Wendy Armstrong, and Jonathan Colasanti, who are leaders in the HIV community in terms of care, advocacy, and research, not only in Atlanta and in Georgia, but throughout the country. And while we have been meeting like this most recently, virtually and on Zoom, I absolutely believe that we'll get, this is pre-pandemic, don't worry. I believe that we'll get back to this one day, you know, and hopefully 2021, I'm very optimistic. And I really, again, want to thank the ERC and Delta Sigma Theta Sorority for this opportunity to be with you guys on World AIDS Day, and thank Tenitra for moderating and Ms. Tanisha Taylor for the invitation. And I really am looking forward to additional discussion. And I'm here if we can share my email address, and I have it up here if you want to reach out at any point in time. And I, again, strongly believe that we'll get through this together. So thank you guys very much. And I look forward to discussion.
Thank you so much, Dr. Lauren. So much information. Wow, I just thought to myself, where do I begin? Some of the information is sort of, we have knowledge of it, and others of it was interesting. So I'll just tell you, I may kind of go here, there, and everywhere because there was so much that I wanted to get into, but I was taking some notes throughout the course of the conversation and may even ask you to pull back up a slide or two because some of the information was so critical. Sometimes the visual is even better than the oral. But one of the things that you mentioned to start the conversation was the concept. You started the conversation talking about the concept of, for example, resiliency as a theme in what we're dealing with this pandemic, but also ended it talking about the health and well-being from not just the physical perspective, but also the mental and the spirit. So I maybe want to start there in saying, from what you've seen in patients, how important it is that, I think it goes without question here, but maybe is sometimes understated, the importance of the holistic approach to dealing with both HIV and COVID.
Mm-hmm. No, it's a fabulous question. And I think, at the beginning of this pandemic, I remember we were all kind of talking about this on the order of weeks. And then it became months. And then it became, well, we're not really sure how long we're going to be in this for, but we know it's a long haul. And I think that, I've seen it in my patients, and I've seen it within, within my colleagues too, that I think that we've all kind of had this realization at different time points that this is a long haul, and that kind of once you come to that realization that kind of we're in this, we're masking, we're, keeping our distance, we're trying to keep our social bubbles small, so that we, minimize, do every effort we can to minimize any potential, transmission risk or spread of COVID-19. And I think that as this has gone on, we've realized it's a long haul. As I mentioned, I think people have had that kind of aha moment at different points. For some people, it was in June. For some people, it wasn't until October, and maybe some people still aren't there.
Not.
But with that being said, I think that once once, you've kind of reached that moment to recognize, all right, we're in this for the long haul, it requires a mental shift, and it requires a shift in your framework for approaching your day to day. And I think that I have really seen incredible resiliency in my patients in terms of once that aha moment's been reached, like, okay, this is a long haul. I think then it becomes about really focusing on the mental and emotional health and well-being, and realizing that we absolutely need our community. And getting back to the resiliency, I think that people are finding incredible ways to be together in a safe way. And I think it was probably a little easier with warmer weather. As parks, I've never seen so many people. We live in Grant Park with blankets out, and, just everyone, having picnics and being able to safely keep distance. And I think, as we move into the winter, it's going to look a little bit different, and maybe be more screen time and connecting virtually. But I've just really, I've heard, one story I can share. I was in clinic yesterday, and a patient shared with me that he and his family, their idea was to basically, in order to keep bubbles small, that they all made kind of 5 of the same dish, and then everyone for Thanksgiving meal, and everyone went around to pick up. So one person did one family did the cornbread, one did the turkey,
Yeah.
and so they all kind of distributed. So they actually all ate the same meal that they had all together prepared, although they weren't exactly sitting at the same table. And I thought that was a really special idea and example of resiliency, where people are just finding creative ways to make this work. And I think, as time's gone on, just having that community and keeping it tight is so important. And so whichever way you can make that work for you and your family, I think is just absolutely essential, especially going into winter.
Indeed, indeed. And there was another word that you pointed out, Dr. Collins, that you mentioned, encouraging. This is what I thought was interesting and encouraging, kind of all in one space. And I thought, I'm going to ask Dr. Collins if she doesn't mind elaborating on this, because it certainly hit me in a positive way. So one of the notes that I took was that the fact that if a person is, infected with HIV, but certainly it is under control, if you will, they don't have any more risk of being affected or infected rather by COVID than the rest of the population. I think that's very encouraging as well, because you could consider that. Certainly my mind went immediately to comorbidities, and I'm thinking, wow, that's a very encouraging thought for someone who's infected by HIV.
Yeah. I completely agree. And I think that it's something that we have all been very surprised by. And I think that in a good way and in the best way possible, I think being really concerned about our patients and knowing that people with HIV can be immunocompromised when not on therapy, how may COVID-19 affect them? And I think it's really been a pleasant surprise that it seems that that people with HIV are not at increased risk. And if anything, that it doesn't seem to be the HIV, but it more so seems to be the comorbid conditions that people with HIV may have, like the general population, like high blood pressure and diabetes and kidney and liver disease and things like that, that kind of the burden of comorbidities may mediate COVID-19 even more so than the HIV for people with HIV. And again, we still need more data on this, but at least preliminarily we can say that that's what it looks like, which I think is really encouraging.
Yes, absolutely. And there was something else you mentioned that I wanted to ask about. The pandemic is providing an opportunity, obviously, to improve HIV care delivery. Have those kinds of ideas that you presented for restructuring care, I think towards the end of the presentation, has that been implemented anywhere? And if so, have you seen success with implementing that kind of creative, we'll call it, approach to healthcare delivery?
Yes, absolutely. So it's really interesting because, so I work at Grady, as I mentioned, and at the Ponce Center. And so my experience is primarily through that lens. And I can tell you that before COVID-19, we did not have telehealth. We did not have a telehealth platform in the clinic. And so we were kind of, I would say, required on an emergent basis to spring up telehealth, which, isn't the best way to do it without, having systems in place. But, I think with all of COVID-19 in 2020, it's a little bit learn as you go, as you said,
Yes.
get creative and make things work. And so I've actually found that for a good number of my patients that they really like the telehealth. And I should clarify that telehealth, I think, can mean video or telephone, non-video, just phone call. And we at Ponce have mostly been limited to telephone calls and don't yet have the video platforming up and running for the majority of patients. But I think it's interesting. And I think as providers, we're going to have to kind of think through. It certainly obviously makes care a lot more accessible to patients or clients. And I think a lot of feedback I've gotten is that it's well received. I think the challenges are, that we can't examine patients if it's a phone call. A video, you can at least do that a little bit more readily by looking. There's still not touch there. But and then it does limit our ability to get labs on patients. They could come into the clinic separately for that. But I think those are a couple of considerations. But in my personal experience, I think patients and clients really like it. I think it's more conversational, and you can catch people in their own space and a little bit more at their own comfort level than the stress potentially and anxiety of coming into the clinic and what that may mean for disrupting their day in terms of, do I need to get on public transport, and what is my risk with COVID-19 considering that? Do I need to arrange childcare? Am I missing a day of work? Does this mean that I won't be able to make it to the grocery store and other considerations? So I think that it certainly makes it more accessible. And we've kind of talked about, could we stagger so it's an in-person visit, then a telehealth, and an in-person visit, that maybe not every visit needs to be in person and face-to-face. And I will say, just as a quick follow-up, that I do know that patients love, it would literally, I think, revolutionize care to not have medications limited to a 30-day supply. That's just not practical. And we have been advocating for that before the COVID-19 pandemic. And now it's just forced the issue, like so many of these things have, that it's just not realistic for patients to come into the clinic to pick up meds every 30 days. And we don't require the general population to do that, for, people that are having diabetes treated and high blood pressure that can get 90-day supplies of medications, and reliably keep that. It just really streamlines care. So I think there are a lot of added benefits, and including mail order delivery and not even needing to come into the clinic for meds, which I know, in my experience, clients have mixed feelings about the mail order delivery. I think they worry about it making it to the home, someone else opening it, things like that. So there are always pros and cons, but I think, in the right populations, that a lot of these measures can be implemented with success and be well received to be more client-centered.
Yeah, and that's one of those nuances, and what seemingly to most of us we take for granted, because we can receive those meds, like you said, up to 90 days in advance as well. That's something that for that population, it's not a given, but it should be. And I think about so many situations in corporate settings, and really settings across the entire country, where many managers thought ill of telecommuting or working from home, and how this entire pandemic process has made them rethink things. So maybe that'll be another one of those positives that comes out of this pandemic in terms of rethinking that healthcare delivery for the HIV population. One of the other things that you mentioned, which I thought was very powerful, and I didn't want to gloss over that, and it's the fact that HIV status, that status should not be a factor in medical decision-making as it relates to triaging. And so I wanted to go back there and touch on it just a little bit more, because I do think it's an important piece. If I may, Dr. Lauren, I know for our community, the African-American community, there have always been challenges just in terms of getting us into vaccine trials, both us being asked to be in those trials, but also the trepidation that is within our community to be a part of those trials.
Mhm.
So now, to your point about those in the HIV community having the ability to be, from a medical decision-making perspective, triage as well as included in those vaccine trials. Can you talk a little bit more about the importance of that and why that is something that's critical as we begin to approach this space of vaccines trials and sort of that next phase?
Absolutely. Absolutely. I think that's a fantastic question. And I think like COVID-19 has shed light on so many like pre-existing challenges in our healthcare systems and public health infrastructure that could use a complete makeover for lack of a better for lack of a better term.
I like that euphemism, Dr. Lauren, but yes.
We need a complete public health infrastructure makeover. And so many of us have been trying to fight that good fight long before COVID. And I do appreciate that, you know, like I said, I think COVID has just really forced the issue on so many of these factors. But the question about trials and as it relates to vaccines is such a good one. It's such an important one. And I will say that, you know, I remember the day actually that was, I think it was earlier in fall, where I'm on Twitter and, you know, there's this, a lot of us are on Twitter in the academic medical community, as I know so many people are. And there was just like all this buzz that Moderna, one of the pharmaceutical companies with the vaccine, that one of the vaccines that's coming out that just recently released their data, you know, made this like game-changing announcement that they were going to include people with HIV. And I kind of like thought to myself, like, one, I was so happy, and two, I felt a little crushed that it wasn't that case all along, you know, that wasn't the case all along from the beginning. And I know that that's just one of the realities that we live in. And so I do think that we're changing that, and Moderna and all the other companies changed that. And when the realization was made and due to intense advocacy, the coin was flipped and people with HIV were enrolled. And I think it is so important, but because we know that the immune system of people with HIV is different, even when it's well controlled. And so that may have effects for how the vaccine functions in this population. Again, even when HIV is well controlled and the CD4 count is high, there still is this chronic inflammation that happens because of a chronic viral infection that is with that person for their life. Unfortunately, there's still not a cure. And so it's really important to, one, know how the vaccines and therapeutics perform in this population, but then also when it comes time, and the time literally is now, for these vaccine companies to be applying for use in the broad population, you know, that use can only be granted for people that were in the trials, meaning that, for example, pregnant women, breastfeeding women are not included. They have not been included in COVID-19 vaccine trials. That's another longstanding issue that many of us have been fighting for, that, you know, for example, pregnant women should be able to make informed decisions if they want to enroll or not enroll and not be outright excluded. But unfortunately, that has not yet been a victory. So once an indication for vaccine and therapeutics is given, it can only be given for populations that were included in the trial. So fortunately, that would now include people with HIV, which is, I think, just is certainly a victory for us during this pandemic. And I think, as you mentioned, so having indications and having access to vaccine is a step, but then we need willingness in the community to take the vaccine. And I know that that's going to be an absolute huge struggle, that, you know, people are willing to take this vaccine. Unfortunately, a lot of you know, I think the public health messaging throughout this pandemic has become extremely politicized and has not, and aside from that, has not been clear. And it is a rapidly evolving situation. So I do understand the need for sometimes stories to change. But I mean, I think that I do worry a lot about the vaccine uptake in the community, which I think if you have an effective vaccine, it's only as good as getting it into the arm of the people. And so I think, as you mentioned, in the African American community and Latinx and others, there's been a lot of mistrust for very good reasons. And I think that it's something that people are actively, you know, that that we are actively working to address. And I'm curious your take on it too, and kind of what you've heard, what you're experiencing, because I think any advice and guidance is welcome, because I think that, I mean, I personally think that the vaccines are safe. They've been intensively studied and scrutinized, and the science is there. And I think how we can, appropriately and consistently message that to the community is the step we're at now, and is going to be a huge challenge. So I would love to hear your perspective.
And that's really interesting, Dr. Lauren, because my undergraduate studies were at Xavier University of Louisiana. And of course, and I'm going to do a shameless plug, but I promise it's for a reason, but we literally graduate the most African Americans in the country who go on to not just attend, but complete medical school. And the reason I mention that is because that's who's in my ear every single day, or that's who I'm on text chains with and emails, just asking them, what are your thoughts on these vaccine trials, and potentially, and it's a question that I wanted to ask you as well, potentially the emergency authorizations of utilizing them, and how it's determined which populations are the quote unquote populations that would be considered to receive those vaccines first. So for our community, the Xavier University community, it's been a very interesting journey, because many of us have been on the front lines with the CDC, with Emory, with NIH, and also our university president, along with the Dillard University president. They chose to be a part of trials, and that was very controversial. Many of the members of our healthcare physician community were not in support necessarily of trickling that down to our student population, which was offered. It goes back to what you said about a little bit of hesitation and mistrust in what these vaccines, what these trials mean for us, for the long term and for our health. But we also know the importance of it. And so there was an acknowledgement and an appreciation for what those presidents did, but maybe a little bit of trepidation for our students to be a part of those trials. So yeah, the conversation continues, it evolves. And so now the conversation is sort of, we're kind of like everyone else in hurry up and wait mode to see whether or not these vaccines that are showing the efficacy, I know you mentioned 90%, I've heard even some estimate up to 95%. Where do we go from here? As far as our support of whether or not my friends in the healthcare community would actually support or advocate for those vaccines being taken. Now, I see there's, there are comments, if you will. There's one comment and kind of one question. So I will kind of loop those all together. And, there is some concern. One of our audience members was saying, I'm not really in favor of the HBC students being in the trial basis. And hey, I understand, because that was the stance that many in our Xavier community took as well. But our audience member, Keisha Kelly, is also asking a great question. Why is the HBCU population, if they were indeed first considered in this instance, why are they often the first to be considered? And as I mentioned, from our perspective, Dr. Lauren, from the perspective of Xavier and Dillard, we are in the forefront of putting African-American physicians into, or pre-med students into medical school, and then churning out physicians. So it's always going to be top of mind for us. But I that's from our perspective. I don't know if maybe you had another perspective on that as well.
It's a very good question and a challenging one. I will certainly recognize that. And I think that, in terms of accessibility, I just think, wanting to be as inclusive as possible to, whether it be, based on age, race, comorbidities, we can only, be able to, I think, confidently, approve the vaccine for a variety of populations, again, based on different demographics, if it's been studied in those populations. And I think, wanting to be as inclusive as possible in that sense, and also honing in on college campuses for accessibility, I think can be really big and helpful in terms of having a large body of individuals that are would potentially be interested in contributing to this science and enrolling in trials to, I think to see if vaccine is effective and safe. And I do think so. College campuses offer a lot of people, and they also offer people that are receiving education, as you mentioned, Tenitra, maybe even in science and health fields, with maybe a greater comfort level for participating in trials. But then I think also wanting to include people, especially initially, that are healthy and don't have comorbid conditions. So that typically would be young people. Now I will kind of turn on myself a little bit and then again say how important it is that we include people on the other end of the spectrum in terms of age too, because we want to make sure vaccine performs well in our elderly populations too. So I think, I think it is a way to target a certain demographic that otherwise, is not necessarily, historically has not been included, and that I think absolutely needs to be, to make sure that it's safe and effective in a variety of populations. So
yeah. Absolutely, absolutely. And I know we have just a few more minutes, so there are a couple of other questions that I wanted to ask as well. And one of those questions was just in going back to something you mentioned, but again, wanted to kind of reiterate, since we are talking a little bit about vaccines at this point, we know that that's kind of where all of the attention is today. And so wanted to see if maybe there was any additional comments that you wanted to make, or any other pieces of feedback about that approval process in particular, because everyone's kind of waiting with bated breath, but kind of what happens there. And then going back to part of the question that I asked in terms of the emergency use authorization, I think that's a big question that everyone has. Okay, great, we have these vaccines in play, they're on the cusp of being approved for distribution, but going back to what Keisha said, if in particular you're looking at the African American, the Latinx population, our elderly population, or our HIV population, how are some of those decisions made in terms of who would actually benefit from or be the recipients of those vaccines first?
Mm-hmm, mm-hmm. That is a fantastic
Complicated.
question. It's a complicated one, and it's an area of active discussion. And I think of weighing risks and benefits. I mean, obviously, we didn't even know about COVID-19, I guess almost a year ago, I can say that none of us really knew about it. Was until really the end of December, early January. So the fact that we even have a vaccine, and that we have multiple potential vaccines that will be available to people in under 12 months is a huge scientific advancement. I do just want to give one shout out to all of the people that have been working specifically on making that reality happen. And I think that is obviously a huge challenge and accomplishment, though I think the more significant challenge is now the distribution. And so you are honing in on that, and I think it's an excellent question, and I think it's one that's layered and it's complicated. I think that what I have heard is that I think most involved parties, CDC, FDA, NIH, the bodies that you mentioned, I think most agree that healthcare workers are I don't mean to say an easy, but a straightforward first pass, because they are actively caring for patients with COVID-19. And so I think that, that decision point is one that's, I think, favored by all. I think although there's still some controversy with that, because healthcare workers have really great access to PPE, and so and most patients coming into the hospital are screened, and so there are nuances with even that decision tree point. But I think beyond that, I do think it has to be our most vulnerable. And I think that, the use of frontline has become a little bit tricky during this pandemic, because, it's evolved over time. And what really does frontline mean? I think, frontline in the truest sense, public facing workers, meaning our educators who, to be honest, are in person with students and not always supported with the most appropriate PPE and safety measures. So I think, you know, educators, people working MARTA in Atlanta, grocery store workers, I mean, to me, that is truly frontline. I think that that's certainly a population that needs to be considered, in addition to those that are most vulnerable to COVID-19 and most vulnerable to not doing well with it. So our elderly community and those that are in congregate settings, for example, assisted living and nursing homes, even thinking about people residing in homeless shelters or in between, and those incarcerated. And I think that, you know, people in all of those situations where they can't appropriately distance, for example, and that are, you know, somewhat unfortunately, in needing to be in close spaces, I think should also be considered. So I think it's not clear, and I think it ultimately is going to be up to states how they decide to distribute. And so, well, it's a little bit for me watch and wait and see what happens in Georgia. But I think it is certainly an excellent question and a complicated issue.
Yeah, absolutely. And it's one that even in the space that I play in, for lack of a better term, we certainly saw, not me personally, but certainly saw a couple decades ago when the HIV AIDS epidemic changed the face of how sports were played, how sports were watched or viewed, if you will, and participated in as well. We're now looking at that same challenge with this global pandemic for COVID. And there are so many spaces that, boy, we're out of time, so we can't get into, but I did at least want to share a couple of quick things for our audience. Just the fact that some of the great work that you've done, whether it's studies on the Southern HIV AIDS epidemic in terms of the mounting burden of non-AIDS comorbidities that you talked about today. Also, a co-investigator for the Women's Interagency HIV study. We didn't get to talk a lot about necessarily how it impacts women, but certainly the work that you're doing in that space and the Specialized Center of Research Excellence on Sex Differences. I definitely wanted to highlight that because there are so many layers to this that individuals, we could talk for hours about individually and collectively about what goes on in this space. But real quick, before Tanisha wraps us up, I just wanted to ask if there is any particular website, webpage, any social media space that you wanted to maybe speak on, where if individuals wanted more information about the ongoing fight, challenges, and even triumphs that are happening in the HIV AIDS epidemic world and the cross of that world with the COVID world, where can they go to find out more information?
That is a really great question as well. I have multiple different sources that I've been leaning on, and I wish there were one centralized source that I could share. I do know through Emory, we're doing a lot of work through the CFAR, the Center for AIDS Research, and we have, on Twitter, we have a hashtag, and we also have our Emory CFAR website, and we have formed like a HIV COVID study group. And if anyone is interested in participating in that or learning more, I mean, you could absolutely go to the Emory CFAR website or contact me personally, and I would be happy to connect. Outside of that, I wish there were a more centralized source that, and hopefully maybe my work is cut out for me in that sense, that I could be tasked with putting that together. But please do feel free to reach out to me at any point. I'm happy to field more questions or just be a resource.
Yes, and that is Dr. Lauren Collins, the Assistant Professor, Division of Infectious Diseases at Emory University School of Medicine. She can be reached at lauren.francis.collins@emory.edu. Very simple, lauren.francis, FRANCES.collins@emory.edu. And on behalf of the Atlanta Suburban Alumni Chapter of Delta Sigma Theta Sorority Incorporated, as well as the Empowerment Resource Center, I thank you all for your time and your great questions. Thank you to Dr. Lauren for joining us this morning. And I will now turn it back over to Ms. Tanisha Taylor to wrap us up.
That's such an engaging session. Thank you so very much, ladies, for opening us up very well this morning and reminding us that both HIV and COVID are viral infections, and the health disparities of years prior are still very relevant today. So organizations like Empowerment Resource Center and Emory University have some work to do to serve our communities, and we are up to the challenge. So we want to thank everyone for joining us today. Those of you all that have connected via Zoom, we appreciate your engagement, your questions. There are many that have joined us via Facebook Live. We so very much appreciate you. Thank you for sharing the pages. We know that this will reach the masses. Just want to remind everyone that we still have 2 more sessions today. A lot of great information. If you love this session, you will love the next 2. All sessions are on Eastern Standard Time, so our next session is at noon. And once again, we'll be covering Keeping It 100, the facts, fiction, and the real deal on HIV. That session, will be led by the Medical Director of Empowerment Resource Center and our medical staff. We'll be talking to you about PrEP. And also, we are a PrEP provider. So if you want to learn more about PrEP and thinking about enrolling on PrEP, which is the ultimate HIV prevention method that exists right now for HIV, please feel free to join that session. Again, it will go live on Facebook at 12 noon. It is not too late to register. So if you have not registered, or if you know someone that might be interested, you can access the registration link through either Empowerment Resource Center's page or the Atlanta Suburban Alumni Chapter of Delta Sigma Theta's page. You can register accordingly. Thank you so very much for your time. Dr. Collins, Tenitra, you guys were awesome. Everyone have a wonderful day, and we'll see you at noon Eastern Standard Time.
Thank you.
Thank you all so much.